Hi, everyone. This is Samira Daswani here, the host of the Patient from Hell podcast. It's brought to you by Manta Cares. We are a global community of caregivers and survivors of cancer. We build and design tools and resources to help us as a broader community navigate cancer with just a little bit more ease than there is today. One of the themes that's come up from this community actually has been around finances. What does it mean to be a survivor today? What does it mean to be a caregiver today? And grapple the financial burden of cancer care. Depending on where you are globally and which country you're in, of course, the nuances here are different. But here in the US, it was my honor and privilege to be introduced to an organization called Family Reach that has been doing incredible work in the broader space of helping individuals like myself navigate cancer from a financial perspective. So today I have Rosie Cunningham here from Family Reach to share a little bit about herself, but also about the organization and us unpacking this very complicated space of paying for cancer treatment. So I'm going to stop here and welcome Rosie to our podcast.
Thanks for having me, Samira. Really excited to be here.
Thank you. So my first thing, Rosie, for you is pretty broad. We'd love to learn about you, who you are, what brought you to Family Reach. Just tell us a little bit about yourself.
Sure. So my name's Rosie Cunningham. I am currently Vice President of Strategy and Alliances at Family Reach. I actually started my career in corporate sales and marketing, selling educational products. And my mom has always been a fundraiser. And so she would always tell me, you need to come over to the light side, leave corporate sales, join fundraising. And in 2013, she was diagnosed with breast cancer. I should say she's doing great now, cancer-free. So we've been really lucky. But it was a little bit of a twist of fate when she was diagnosed, because at the same time I was relocating down to Austin, Texas, and I came across the Livestrong Foundation, who was looking for someone with corporate sales experience to come in and help with business development. So I joined Livestrong, fell in love with the cancer mission, the community, really just fell in love with being a nonprofit in general. And a couple years later, my husband and I were moving back up to the Northeast, and I just found Family Reach online. So I applied for a job, and part of my interview process was to attend an open house, which is an event that Family Reach hosts every year, bringing our families and donors together. And I had the chance during the open house to meet some of our families and hear their stories. And during the open house, I met a single mom who, despite having a modest savings, lost everything when her son was diagnosed with leukemia. And she had to stop working to be by his side in treatment. And she was evicted from her home during her son's cancer treatment. And she moved into a homeless shelter during his treatment. So she would literally take her son to treatment and then take him home to a shelter at the end of the day. There was no way out of this for her, because she was not going to choose work over being by her son's side. Leukemia treatment is really intensive for a short period of time, and she wasn't going to send her 4-year-old to treatment alone. So this is where she was. So Family Reach was able to step in, find her an apartment. We paid first, last, and security and a couple of months' rent. We made sure that she could keep food on the table. And I was hooked, just seeing in person that tangible impact that we had on real families, and recognized a great opportunity to be part of something big and make a difference. So I've been with Family Reach since then. That was 7 years ago. And I've had the privilege of growing the team, being part of growing this team. We have a stellar group of humans working at Family Reach. When I started, there were 9 of us. Now there's almost 50. And it's just been amazing watching us grow from more of a regional nonprofit to a national thought leader on this issue of financial toxicity.
Rosie, thank you for sharing that story. I think I hear sadly stories like that often in the space, but to hear how Family Reach can intervene and support, I think gives me at least some ray of sunshine that there is something that we as a community can do. So thank you for sharing that. I'd love for us to unpack financial toxicity. I think we both have mentioned it now a couple of times. I know there's a lot of opinions on the definition on it, a lot of different perspectives on it. And I'd love for us to sort of unpack that together.
Yes, such an important conversation. And there really are a vast array of contributors to the problem of financial toxicity. So it is hard to point to one or two. And I think everybody comes at it from a different angle, depending on the work they're doing and the perspective they bring and the experiences they've had. There is, of course, just our healthcare system and how we manage pricing and cost. So despite policy efforts and kind of positioning from cancer care providers and insurers on price transparency, there is still very little transparency about the cost of treatment in the United States. Cancer is complicated, as you know, all too well. It's not just as simple as, is my chemo covered? Is it an oral chemo? Is it covered under my prescription benefit? Is it intravenous? Will it be covered in a different way? There are endless referrals, endless specialists, who's in network, who's out of network. And there's also a debate happening right now about whether or not providers are oversubscribing treatment, which is resulting in higher costs. People with cancer are in crisis, so it is completely unreasonable to expect that they have the capacity to manage and navigate all of this. There's also another side of it, which is where Family Reach comes in and where we focused, which is really rooted in what is happening at home. So this mother that I talked about earlier, she lost her income. 2/3 of people living with cancer are unable to work full-time after a diagnosis. Of the families we serve, 65% of them have lost over half of their household income. So before you even get into the web of healthcare costs that I just kind of barely scraped over, you're already in crisis. You're already unable to make ends meet. So we know that 1 in 3 families are unable to meet basic needs during cancer treatment. This means they're not able to put food on the table. They're not able to pay their mortgage. They're not able to pay their rent. And it's just unacceptable. There are also hidden costs that are often missed, like childcare. If you are a parent and you have to go to treatment, who is dropping the kids off at school? Who is with them at home? If you have siblings, where are they going? And COVID-19 really exacerbated this problem when siblings and children were not able to attend appointments with patients. And then there's transportation and access to care. Are you paying $10? Are you paying $40 to park every time you go to a treatment center? Are you able to put gas in the car? Are you immunocompromised so you can't get on the bus? Patients are having trouble just even pulling together the money to physically get to treatment on time. One other thing to add, Samira, is that people with cancer are more likely to file for bankruptcy. But beyond that, people who do file for bankruptcy are 79% more likely to die from their disease. So financial toxicity is not just a financial problem, it is literally a life or death problem.
Rosie, I have goosebumps in just hearing you talk about this, and I'm familiar with the data, and I still get goosebumps just listening to this. So I appreciate you sharing that. I think it's one of the reasons why I am sort of very glad to have you guys on this podcast, because I think it's not just so prevalent, it's also underspoken about. Like, we don't talk about it. I'll give you a small example from, you've seen the planner that we made. And one of the things in the planner is there are questions in there on helping individuals navigate insurance and asking questions around prior authorization, etc. And we got feedback from, by now, hundreds of patients and families. And you hear them say the following thing: I don't want to think about it.
Yep.
In our planner, we had it up front and center. And then the feedback was, I have to do everything in my power to get treatment. And therefore, I will not talk about it. So there's also I want to say stigma. Stigma might not be, it's too broad a word, I think. It may be shame, it may be guilt, it may be this desire to hold on to life in a very specific way. And I don't know if you've sort of encountered that in some of the work around financial toxicity.
Yes, this is a serious problem that we face, and I would call it stigma, certainly shame. The topic of personal finance is inherently personal. We as a society are not used to talking about our financial circumstances in the open. It's assumed that we are managing our own situation and we are making it work for our families and keeping everyone afloat. When you add to that the extreme layer of vulnerability, when someone who you love or you are sick, you are already in a vulnerable position. You're navigating an extremely complex space. You're literally learning a new language when you are diagnosed with cancer, as your planner is designed to help with. So whether it's shame or simply just not having the headspace, like you said, people are not comfortable raising this issue with their providers or with a nonprofit, whoever it might be. I also think we haven't necessarily done the best job creating that space for them. We work with social workers, navigators, oncologists who refer patients to our services. 74% of those don't have a financial screening tool. So if patients aren't being screened for financial hardship, how are the clinical teams going to identify their needs? Those who do will often push back on us at Family Reach to say, I'm not going to ask my patient about whether or not they can stay on top of their mortgage. That's not my job. And I don't have resources to give to them. So why would I ask about a problem that I can't fix? So it's not only the shame that the patient feels, it's also kind of a stigma that the clinical teams are feeling because they feel like they don't have a solution. And so there's a fear on that side as well to bring up the issue.
I very much resonate with that, Rosie. I'm incredibly privileged to be on a PPO plan. I worked through treatment, so I was incredibly privileged in the world of cancer, right? So I don't think it's kind of equivalent, but even for me, I know it came up very, very early on. My first imaging happened end of December 2019. And I remember that I was sitting at this ultrasound, arm above my head, bare chested. The technician calls the radiologist in, and the radiologist comes and repeats the ultrasound. And she looks at me and she goes, I need to do a biopsy right now. And I was fortunate to have worked in healthcare. And I look at her and I'm like, how much will it cost? Mm. And she's like, I have no idea. I was like, well, I'm not going to do it then. And she goes, you have to do this. Like, I am telling you that this is a problem, that there is a very high chance that this is going to be cancer. I highly recommend you do the biopsy. And I just remember sitting there going, it's the end of the year. My insurance is going to change in about 10 days. If they do a biopsy right now, it means that the minute Jan 1 comes around, the clock resets, everything resets, my out-of-pocket resets, my deductible resets. And I'm asking her a simple question. I have no idea if this is going to be a $10 bill or thousands of dollars. I have no idea. She's not giving me any sense of it. And I just remember going, you know what? I need to talk to someone who does. And I remember thinking, my family's going to be really mad at me. Because I don't think they would have made the same call, right? I think they would have pushed me to be like, Samira, what are you doing? Don't think about the cost. Just go ahead and get the biopsy. But I just remember making this like on the spot call, and looking back, I don't regret it because I was lucky. Early stage breast cancer, like it was not, I didn't put myself in too much danger, but I can imagine situations in cancer where that decision could have gone very, very badly in a different context.
Absolutely. So, absolutely. And your background in healthcare was critical to you being able to make that decision. And yes, that knowledge is just a luxury that most Americans do not have.
Yeah, I fully agree. And I think that that's been the piece that has struck me over and over again in the space that we're talking about, because this actually goes back to the second theme that I was hoping we can unpack, which is the health inequities and how health inequities and financial toxicity, at least to my naive eyes, sort of seem very interrelated to each other. And I don't mean health inequity in the sense of just economic. I mean it, you can be a biology major and have serious health inequities and have literacy and have health inequity. So I don't know if you have any more thoughts on how those two themes sort of interrelate with each other.
Yes, I think they're inextricably related. Our mission, which is to alleviate the financial barriers that stand between a patient and their treatment, is just rooted in health inequities, whatever those inequities may be. And for 25 years, we've served patients from across the spectrum who are unable to get to treatment because they can't afford it one way or another. Over the last decade, we as a cancer community have done a better job looking more closely at these inequities and charging ourselves to really challenge and understand the roots and do better to close the gaps. At Family Reach, what that has meant for us is to really hone in on low-income Black and low-income Hispanic Latinx patients. And the reason for that is because these two communities are most adversely affected by the financial burden of cancer, which is rooted in structural racism that has both a historical and a very present place in our healthcare system. How we create resources, how we distribute them, how we access them, how we design them, who we design them for. And a few key contributors to this problem include the facts that Black and Hispanic patients are more likely to be uninsured or underinsured or on Medicaid. They're more likely to be unable to afford a $400 emergency. So the story you just gave, Samira, that's it. There's your emergency, right? Like that copay could have come through the next week. And there's a huge percentage of Americans, very many of them Black and Hispanic, who would be unable to manage that cost. To go back to the shame conversation, Black patients in particular are more likely to experience mistrust due to a long and complicated history of racist activities in the healthcare system. And so if we as Family Reach are saying, we're here to offer financial services, just talk to your healthcare provider and they'll refer you to us, that is a major barrier in our system that is preventing us from reaching patients who need us. Most importantly, we know that both Black and Hispanic patients are more likely to report non-adherence to treatment. And so when we talk about this being a life or death issue, there it is. It's simple. Yeah. If you are not adhering to treatment, you are going to have poorer outcomes. So the way that we are approaching this, and I know every organization is doing things a little differently, we are reaching out to community organizations who are already entrenched and embedded in the Black community, in the Hispanic Latinx community. And we are making sure that their navigators or their caseworkers, their community workers know about our resources so that when they are sitting with a patient, getting them screened within their treatment appointment with their oncologist, and they hear them say, oh, I can't get here because I can't afford the bus, or I can't, whatever it might be, the community worker is actually delivering our services. So we are very intentionally not creating another pathway for patients. In many cases, these families don't even know it was Family Reach who helped them. We are really trying to meet patients where they are with people they already trust to remove some of those barriers. So this is a program that we launched about 6 months ago, and we're really looking forward to looking at what comes out of it. Are we reaching the right patients? And more importantly, is our program having the same impact on treatment adherence, on access to care, on financial distress? And if not, why? And where do we need to kind of make changes? So this type of work, this type of really looking at the data to understand where the inequities come from is how I think we as a community, again, have been doing better. But I think it's that next level of, okay, as we uncover this data and learn, what are we going to do about it so that we can really address some of these inequities in the long term.
Yeah. Rosie, I'm super glad you shared that. It's almost a little unfair for me to say the following thing, so bear with me. But it always strikes me when, and I do this all the time too, when we are sitting in this room, virtual room, and talking about a community that is not here. I know I react really badly when there's a reason why the podcast is called The Patient from Hell. I react very badly when even my oncology team is talking about me and I'm not there. Mm-hmm. So to have a community where we are talking about them, but they're not present, is something that I want to do my part in helping shift the dialogue on. So random tangent that we don't have to go down. But I want to pull that back. The reason I mentioned that is one of the things that we've been trying to do on this podcast is there are all of these topics that sit in kind of the scientific realm, in the study realm, in the oncology space as a whole. If you look at our entire ecosystem, there are pharma companies, insurance companies, like hospital systems, patient advocacy groups, for-profit groups. There's so many players in here, and the language I think that is shared across most of those groups is sitting in the realm of program effective studies, monitoring and evaluation studies. How do we gauge ROI on return on investment on a specific program, product, service, treatment, etc. What I think sometimes is missing is just the practical things that patients and caregivers can do. And I'm wondering if we can come up with a couple of things that we might be able to leave our listeners with, being like, if you get diagnosed with cancer, here are 3, 4, 5, 6 things that you would want to start to do. It doesn't all have to happen right now, but here are 5 or 6 things that we can leave them with that are, they won't solve everything, I'm almost certain, but it may leave them with a little bit of agency that we don't have today. So yes. I don't know if you have anything top of your mind, and we can co-create a list on this spot.
All right, I love it. At the risk of pushing Family Reach products, I want to...
You're not risking it, don't worry. We want to push your products, so you're
fine. So we have a financial guidebook, and I know we've talked about this before, Samira. So the financial guidebook is a brief piece, and it's really designed to alleviate the shame, just set the stage for patients. Finances are going to be a part of your journey. Here's a couple of worksheets, a couple of topics that might help you just begin to think about, are you going to lose any income? If so, what is that going to mean for you this week, this month, right? Like start small. And so it seems so simple, but for me, that monthly budgeting, because we live in the world of what's happening at home with a patient's finances, is completely critical to helping make sure that patients don't find themselves in a place where they're 3 months behind on their rent, and they're coming home to an eviction notice, which we hear about all the time. So I think step 1, looking at your monthly budget, recognizing that's a lot to do right now when you're digesting the news that you've just gotten a cancer diagnosis. Call Family Reach, right? We can help you do that. We can set you up with a coach to help you do that. But it's just that awareness that finances are going to play a role here, and let's just check in to see where they could pop up.
And if you don't mind, let's maybe build on each other. I'm going to throw out a couple as well. One is, if you are someone who doesn't have insurance, a lot of pharma companies do offer patient access programs. Getting through those programs is, and I know this from personal experience, painful, but they do exist. So if you do some legwork, you might be able to get coverage as well from that side.
Yes. And another resource to help with that would be groups like the Patient Advocate Foundation or the Patient Access Network. We're also seeing more and more community cancer centers are hiring financial navigators who that is their job, to help connect you with those copay assistance funds, sometimes even the free drugs that are available. So if you can, ask somebody on site at your treatment center, is there a financial navigator here or someone who can help me with this?
That's awesome. I think we've got 3 or 4 right now. So it's maybe number 5 would be, if you are insured, prior authorization is a key question. Essentially, the treatment center should be doing this, but often it doesn't happen in time. So making sure and asking the question as to whether your doc and their care team have done prior authorization will make a big difference, because then it's not necessarily a surprise bill, or it shouldn't be as much of a surprise.
Yeah. Yeah. And it's, even just listening to us, Samira, throw these ideas out, they're all so important. And so I think the challenge for us and, our peers in the space like PAF and PAN are to really come together and to help patients figure out, okay, what's the order that you need to do these things in? Is it supposed to be prior authorization first, or do I need to figure out if I can pay to get to treatment this week? A lot of us are doing such important work. And if we can find ways to come together to create tools that really unite all of this and help streamline it, I think it will make it a lot easier for patients to digest what we're suggesting here.
Rosie, I love that. So I'll give you an example of what happened in a separate podcast. And one of the things that's coming out of it is we were talking to a survivor who is a breast cancer survivor who got medically induced menopause. And it's not the same thing as financial toxicity, but what happened is, based on the podcast, we ended up realizing that there's a lot of information sitting kind of just in different parts of our community. So one of the things that we're doing right now is we've basically opened up a super simple Google document where different survivors who are going through medically induced menopause are putting in their thoughts and ideas and tips and tricks that they have done. Of course, this is not medical advice. We're not saying it's the right thing to do. We're just almost crowdsourcing the information and giving it away for free. So there may be something that comes out of this podcast where we pull in the other 2 organizations you mentioned. I know them as well. And we can do that. We can come up with a checklist being like, if you are diagnosed, here is 1, 2, 3, 4, 5, 6, 7 things that you can do. Yeah. And we can distribute it across our communities and see if it just gives them a starter piece, right? Because sometimes even the planner is too much, the guide is too much, it's too overwhelming. You don't know where to start. What's that 1 thing, 2 thing, 3rd thing that you can do today that can make a difference? So maybe that's something that comes out of our discussion today.
I love that idea. And I think to take it a step further, if it's something that we could also share with treatment centers so that the social workers, navigators are equipped with it too, that would be incredible. Speaking of inequities, one thing that we've also come to realize is how much of our program is reliant on virtual delivery. So we're also doubling down again on print and getting things out within communities, not just within treatment centers and not just online as well.
The not just online is huge. That one is huge. The planner is paper-based, of course, right? And it stays that way for precisely that reason, which is technology today, given all of its benefits, it allows us to have this podcast. There's a lot of things that it enables, but to a large extent, I think, in some of the areas we're talking about, I think it honestly just doesn't meet me where I am. And I'm a technology savvy person. I'm like, sometimes old school is the way to do it. I had someone tell me yesterday, Rosie, you laugh at this. I had someone tell me yesterday, paper is innovative. I was like,
that is so true right now. That is good. I'm going to go into my next budgeting meeting with that. Amazing.
So we've covered a lot of things today. So we've covered financial toxicity, health inequities. What are the sort of practical 1, 2, 3, 4, 5 things people can do? We also have an action item for ourselves from this podcast. And we'll, of course, link to it from our show notes, because hopefully by the time this gets published, we've actually put it together. So that way we can release it together as well. Is there, the question I had for you, I remember my question now. Sorry, I kind of forgot. I very often use the magic wand question, but I think in this context, I think it's particularly relevant which is if we gave you a magic wand and you could have 3 things that you could change in the space, what would they be and why?
Yeah, such a good question. We use the magic wand question a lot in our meetings as well. So I love that you do too. I think the first thing, and we've touched on it a few times, so I don't want to harp on it, but just that every family comes into cancer knowing no matter where you are starting, that finances are likely going to play a role, but more importantly, that help is available and that there is no shame in asking for help. And we've talked a lot about why that one matters, but we just hear constantly from the families we speak with on the phone. Our navigators are listening to families tell stories about not being able to feed their kids. And they're still saying, oh no, don't help me. There's probably another family who needs it more. There is help out there. There is help out there for everybody. And there is no shame in asking for it. That would be my first wish, that everybody understands that. My second wish would probably be that there is a system in place, whatever it may be. We're piloting a few different approaches right now, to just ensure that during active treatment, every family has the ability to maintain the basics: food on the table, a roof over their heads, and gas in the car or transportation, whatever that looks like for each family. This is like a human decency issue. And we, as Americans, are letting our neighbors lose their homes, lose the ability to feed their families, feed their children because of cancer treatment. So what is the system through which we can ensure that those 3 items, food, housing, and transportation, are not an issue for patients? The third, I mean, you gave me a magic wand, so am I allowed to just wish that financial toxicity was not a problem? I mean, that is my wish. Family Reach would be out of business, but that would be okay. That would mean we did our jobs. So that would be my last wish.
Rosie, I love it. I think that's exactly right. I honestly think the day we don't have a business and a role, I think that's the day that we should celebrate. So I'm completely with you, and I really appreciate you sharing your 3 wishes. I think they're a little bit broader than 3, but I'll give it to you.
I tend to do that. I tend to pile on. Just add a couple more in there.
I almost cut you off at one, being like, I think that's like 4 or 5 in there, but okay, all right. We'll let it slide. Rosie, thank you for coming today. I think we've covered some pretty critical topics today, and I am hoping that this podcast and the show notes and the many, many endeavors of Family Reach reach the people at the right time when they need you guys, because I truly, truly understand how bad it can be, and I'm so glad you guys exist. So thank you for coming.
Thank you for having me. Thank you for including Family Reach, and likewise, just love what you have done with Manta Planner. It's pretty amazing what you've accomplished since your diagnosis. So thanks for including us, and I'm excited to keep working together.
Thank you so much, Rosie.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have, and should seek the assistance of their healthcare professionals for any such conditions.